And I have the pleasure of introducing our speaker for today's session. Dr. Anna Maria South is an assistant professor in the College of Medicine's Division of Hospital Medicine and is an attending physician on the Addiction Consult and Education Services, or ACES team at UK. She graduated from the Ohio State University with a Bachelor of Science in Biology and received her MD from the Boonshoff School of Medicine in Dayton, Ohio. She completed her residency in internal medicine at UK and then joined the Division of Hospital Medicine as a hospitalist. She has been the recipient of numerous medical student teaching awards, as well as awards from her division for patient advocacy and excellence in patient care. She also serves as one of the health equity and advocacy thread leaders for the College of Medicine. In 2022, Dr. South was selected as the UK Bell Addiction Medicine Scholar, a position renewed in 2023. So please help us all welcome Dr. South, our speaker today.
So thank you so much for coming to today's KY Open. I'm going to be talking about a topic that is very important to me as far as patient advocacy goes for our patients with substance use and specifically opioid use disorder, and how we as providers and advocates can use the Americans with Disabilities Act to help advocate for more access to medication for treatment of opioid use disorder. I don't have any relevant disclosures. And as I've mentioned, there is some practice gaps. So patients with opioid use disorder are protected by the Americans with Disabilities Act. And this is a new development as of April 2022. So a lot of patients don't know that they have these protections. A lot of providers, social workers, peer support counselors don't know that our patients have these protections. And then we often don't know how to use these protections for our patients by either filing a case or reporting a violation of the ADA. So the goal of this session is to explain how the ADA applies to patients with opioid use disorder, and then also explain how we can use it to advocate for them so that our patients can have increased access to medication for opioid use disorder. So first, we're going to go briefly over the ADA, the Americans with Disabilities Act, so that we're all on the same page as to what it is. We're going to briefly review medications for opioid use disorder. That's obviously a completely separate talk, and I'm assuming that a lot of you know most of this information already. So we're just going to hit the highlights as they apply to this session. And then we're going to talk about how does the ADA apply to patients with opioid use disorder, and discuss some important landmark settlements that have been reached using the ADA in protection of patients with opioid use disorder. And these settlements are going to be some from across the United States so that you guys can get a kind of a background of how this has evolved, but also some that have happened in our state here in Kentucky. So you can see how advocacy works firsthand for our patients in this current state. I just want to set the guiding principle that we all should be aware of. Opioid use disorder is a chronic medical disease. And just like any other chronic medical disease, we do have effective evidence-based treatment available that is mortality reducing. The ADA in general is a civil rights protection act that gives protections to people with disabilities. And we know that opioid use disorder limits one or more major life activities. So for example, the ability to care for oneself, the ability to work or maintain some relationships. And so therefore, it is one of the disabilities that falls under the ADA per the federal government guidelines. And we will explain all this a little bit more because this is rapid fire. We also know that it is illegal to discriminate against patients if they are on medication for opioid use disorder against that under the ADA. And you know, I'm a physician, so I speak from my role as a physician, but also in everybody's role of taking care of these patients, be it as a social worker, a peer support specialist, a nurse, a pharmacist, any provider, or anybody really that works to help these patients. It is our role to advocate for them so they can have the best medical treatment available and so that they're protected against discrimination by public entities. So with that, this is going to be a little bit interactive. We're going to start it off with a case. And this is a real patient case, and that's one of the settlements we're going to discuss. So this is a 24-year-old guy who had cystic fibrosis. So cystic fibrosis is a disease of the lungs that is life-limiting, and people actually need often a transplant as part of the treatment. He has opioid use disorder, and this was because he was prescribed opioids as a child when he was hospitalized for a complication of his cystic fibrosis and then developed opioid use disorder. He's very engaged in treatment. He is on buprenorphine. He's taking his medication as prescribed. His urine drug screens are appropriate. And he's in a counseling program for his opioid use disorder. However, when he goes to the hospital to be evaluated for a transplant, the transplant surgeons decline him for a transplant based on his history of opioid use disorder and being on buprenorphine. And I know since this is on Zoom, we can't really do groups. So I'm going to ask you to just think about this for about 30 seconds about these questions and then unmute and talk. And there is no wrong answers. You guys probably don't know a lot of this. I didn't know this before I started reading more about it. So this is just a discussion. Do you think the decision by the transplant team to deny evaluation for transplant seems just? And what even is justice in medical ethics as it applies here to this patient? Do you think this could be a potential ADA violation? And what could you do in your roles to advocate for this patient? Are there any thoughts, or are we too shy since we haven't gotten into the meat of the presentation yet? Something in the chat. Yes. So Tanya says she thinks it's a violation. Absolutely, right? This is a potential violation of the ADA. Could be, Katrina says, could be potential ADA violation if OUD or MUD is listed as exception without more specifics of clinical reasoning for this patient. Absolutely, right? Any other thoughts? What could we do to advocate for this patient? Right. How is this just distribution of available resources, Carl asks. Absolutely, right? This patient is being excluded from resources that are available just based on the fact that he has opioid use disorder and is on MOUD. Any thoughts on what we could do to advocate for this patient? Going once?
Hey, Dr. South, this is
Yes.
Carl Williams. I just
Hi.
wanted to ask, and maybe I missed it when you're going through the case. Was the reasoning for denying? Was there any medical reasoning for denying access to
No,
this
that's a
resource?
great question. Yeah. So the reasoning was that he cannot be evaluated. So they declined even the evaluation for a transplant. So he didn't even, pass the first step to be evaluated based on being on buprenorphine. So absolutely, I think that's a very important point that Carl is bringing up. This patient didn't get evaluated, right? Like it wasn't like somebody evaluated him and said, there's certain things that are make you not a candidate for transplant, but they categorically said this patient is on buprenorphine and cannot be evaluated for a transplant. And this decision was made without involving a specialist like an addiction medicine physician or a pain physician to evaluate where is this patient in their substance use history, how would, is pain management an issue, things like that. So they just categorically declined him. Yes. So for the advocacy, I think Candy and Katrina put some things in the chat. Speaking to the transplant team or just for the provider that is writing the MOUD to give a history to the treatment plan, to the transplant team. Absolutely, right? Reaching out, seeking a conversation, saying, what's your reasoning for declining this patient? Because there might be a knowledge gap on the transplant team side that they just don't understand what buprenorphine is or what is opioid use disorder. They might have some stigma and not recognize that opioid use disorder is a chronic medical disease, just like diabetes, that we have treatment available for. So getting more information, that would be a good first step for advocacy. So I'm going to ask you to keep this case in mind. as we go through the presentation, and just to keep you on the edge of your seat, I will tell you later what happened in the settlement for this patient. So the first thing we're going to talk about is the Americans with Disabilities Act. And this is a federal civil rights law that was passed in the 1990s. And it basically prohibits discrimination against people with disabilities in everyday activities such as work, transportation, housing. So what you might have seen is that, public buildings have to be in compliance and accessible for people with wheelchairs, with either ramps or elevators, things like that. So that's the very basics things of the ADA, but it also means you can't refuse to employ somebody because they have a disability that's protected. And this is to be followed by government institutions and public entities. So to simplify that, anything that really serves the public, even if it is under a private payer source. So for my line of work, that includes hospitals, obviously, clinics for patients, even if they only take private insurance. It includes SNFs or physical rehab facilities where patients go, but it also includes jails and prisons. So that is the ADA. That was very brief, just so we all understand what the ADA is. And if there's questions on the ADA, just put it in the chat and I will try to answer them. So now it's going to be the briefest review of MOUD you have ever encountered. So we know that the opioid crisis, unfortunately, is still ongoing with significant overdose deaths and mortality and morbidity overall from substance use, increased hospitalizations due to injection-related infections. And this has gone up even more in the era of fentanyl, unfortunately. But as I've mentioned, we do have medications available for the treatment of opioid use disorder. And I just want to go through all three of them real quick so that everybody knows what we're talking about through the rest of the presentation. So there's methadone, buprenorphine, and naltrexone. And for the people that are more medical in the audience, mechanism of action. So methadone is a full mu receptor agonist, buprenorphine is a partial mu receptor agonist, and then naltrexone is a mu receptor antagonist or blocker. So you might hear your patients use those words. And why the mechanism of action really is important is because both methadone and buprenorphine treat cravings and withdrawal. We know for naltrexone, it does not treat withdrawal. So if somebody is in active opioid withdrawal and is given naltrexone, that is not going to alleviate their withdrawal symptoms. There is some evidence that there is some benefit in treating cravings, but most of those studies are from countries where methadone and buprenorphine is not allowed. So those are not head-to-head comparison blinded trials, which is the standard for evaluating these medications if you were to compare them. And this is the really important part now coming up, talking about mortality. We know that both methadone and buprenorphine reduce all-cause mortality as well as reduce mortality related to opioid overdoses. So I really want you to keep this in mind because that's why it's so important that our patients have access to these medications. Methadone and buprenorphine keep people from dying, and that's all-cause mortality. So when I'm talking to my patients as a doctor, that's really the best thing that I can tell my patients when they ask me, why should I take this medication? I can tell them it's going to reduce your chances of dying. We do not have that data available for naltrexone. So this is the only one out of the three that does not have mortality reducing data behind it. And the FDA approval are slightly different for methadone and buprenorphine. It's approved for treatment of opioid use disorder, and naltrexone is approved for relapse prevention. So when I talk about mortality reducing MOUD for the rest of the presentation, I'm going to be referring to methadone and buprenorphine. And this slide is one of the most important slides, I think, in any talk about opioid use disorder. When you compare the mortality of somebody that has an untreated opioid use disorder and you assign a generalized standardized mortality ratio of 1 to the general population, somebody that has an untreated opioid use disorder is 6 times higher than the general population. And that's just talking about mortality. This is not talking about morbidity and all the other chaos that we know that our patients that are in the middle of addiction are experiencing in their lives. But if somebody is on medication that is mortality reducing, like methadone or buprenorphine, that mortality goes from 6 times as high to about 1.8 times as high of the general population. So significant mortality reduction. And for the medical people that are here in this presentation, I challenge you to think about your own practice and find any other medication that we prescribe patients that have such a high mortality reducing effect. This is now my 9th year as a doctor, I think, and I have not found any medication that is as mortality reducing as buprenorphine and methadone. So that's why it's so important for us to use the ADA so that our patients do not get forced to discontinue this mortality reducing medication. And with that, we have reviewed MOUD. So now we're going to get into the meat of the presentation. I'm going to take a 30-second pause to see if anyone has questions about either of the 2 first learning objectives. All right. So now let's talk about how the ADA applies to patients with opioid use disorder. That's why you all are here to learn that. So as I've mentioned before, opioid use disorder can substantially limit one or major life activities. And by that, the government defined that as the ability to work, to maintain meaningful relationships, to take care of oneself. And therefore, the federal government and the Department of Justice actually included the opioid use disorder as a disability that is protected under the ADA. And that is new, as I mentioned, as of April 5th, 2022, when that statement came out. So while there had been case settlements before that had approved that and been in line with that, this is an official government statement that is now stating that we can cite when we advocate for our patients. And in that statement, the Department of Justice stated that withholding medication for opioid use disorder as a policy not to do to an individual medical assessment is a potential ADA violation. And I want to explain that further. So if I say, yes, you can come to my SNF, my physical rehab facility, absolutely, but I do not allow you to be on buprenorphine while you're here. Nobody in my facility can be on buprenorphine. That's a violation of the ADA. If I say, okay, I'm assessing you as a doctor, you've had torsades, which is a heart rhythm abnormality from being on methadone, and you almost had a fatal side effect from that. And I think at this point, your benefit of being on methadone is outweighed by the risk it's causing to you or potentially causing to you. I would like to maybe taper the methadone down, reassess, see how things are going, and keep you safe while we're doing that. That would not be an ADA violation because I'm performing an individualized physical assessment. I see maybe why at this point the MOUD is not in the best benefit of the patient. And then I have a discussion with the patient about why at this point maybe being on methadone is no longer beneficial. And then the patient still has the right to make an informed decision about their treatment course going forward. Versus if I say, you can't come to my facility while you're on this medication as a blanket policy, that is a violation of the ADA. Similarly, if I say everybody that comes to my facility, I'm going to force them to stop their medication for opioid use disorder, that's also a violation of the ADA. One thing that is not protected under the ADA is active substance use in certain circumstances. So that's kind of the exception of the ADA. But then the exception of the exception, which is anytime there's a law, there's an exception, and then there's an exception of the exception, is withholding medical care. So facilities are not allowed to withhold medical care due to active substance use. So if somebody comes to an emergency room and they've had active substance use and have a medical health consequence from that substance use, the ER can't say, well, we're not going to treat you because you've used substances. That would be a violation of the ADA. There's also other laws, obviously, that play into that, right? EMTALA, things like that, that would violate, but that's a very simplified way of thinking about how the ADA protects people with opioid use disorder. This is, as a doctor, for me, laws and legal things are always kind of complicated. So I'm going to pause here to let you ask some questions if you have any. All right. And this is the Department of Justice release that came out on April 5th, 2022, as I've mentioned before. So it's a little over a year old, that clearly stated people with opioid use disorder have a disability under the ADA. And this protects individuals that are on opioids that they take legally prescribed by their provider. So if they are on oxycodone for back pain, but it also includes MOUD, so methadone, buprenorphine, naltrexone, all are included. It also applies to people with opioid use disorder who participate in a substance use treatment program. And then it does apply to people that have a history of opioid use disorder in the past that are no longer using any substances. So all of those are protected under the ADA, according to the Department of Justice. So, since I've explained what the ADA is and who is protected, this is an audience participation question, multiple choice. Which of the following is not a potential ADA violation? A city terminates an employee because they are on MOUD. B, a hospital refuses to employ a physician because of their history of opioid use disorder after the physician discloses that they completed a residential treatment program. C, a nursing home refuses to hire a nursing aide because their urine drug screen was positive for fentanyl that was not prescribed by a physician. D, a public library terminates an employee for taking oxycodone prescribed to them for chronic back pain. Okay, I see lots of things in the chat. C, 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 C. Wonderful. Wonderful. Perfect. Yes, you guys are all rock stars. You all got it right, right? C, so active substance use is not protected by the ADA if, you know, for employment, things like that. If this nursing aide had some sort of health consequence and presented to a hospital under the ADA, they are still eligible to receive medical care. So you can't withhold medical care, but yes, you discrimination based on employment for active substance use is not protected under the ADA. Formulary question, let's see. What about for reasons of formulary, Katrina asked. So is that if somebody says like, you can't come to our facility because we don't have buprenorphine on formulary? Is that the question?
Yeah, that's the question. And then also, you know, like if there was a medical service and they say, well, that's, you know, that's outside the formulary of opioids that we will cover.
Yeah. So I think some of our cases will go through that in a roundabout way, but basically the simple answer is that is still a violation of the ADA. And what I've done when I talk to people about that is I ask them, well, what do you do with other controlled substances? Like, how do you get those things on formulary? So sometimes, you know, people have like certain cancer drugs not on formulary due to cost, but then they would apply maybe the patient to bring in their home supply. So if you do not have buprenorphine on formulary, then you're obligated to find a way to get it on formulary. And for methadone, it's obviously more tightly regulated than buprenorphine. But people that are in a closed pharmacy system are able to dispense methadone. So that's how we are able to dispense it at the hospital. That's how people at rehab facilities are able to dispense it. So that should not be an excuse to not admit a patient there. And if they can't do it, then maybe they need to figure out transport to the methadone clinic. Did that answer the question?
Yes, thank you. No, looking forward to the cases that'll show that. Thanks.
Yeah. Let's see. All right, going forward. So now we're going to talk about some landmark settlements. And I know you all have been waiting to hear what happened to our patient that was waiting for a lung transplant that needed it as a life-saving measure for his cystic fibrosis, but the transplant surgeons refused to evaluate him based on his history of opioid use disorder being in treatment on MOUD. And this is actually, to my knowledge, the first settlement case in the United States that used the ADA as a pointing out that discrimination against a patient with opioid use disorder on medication is a violation of the ADA. So this was a settlement from 2020. This was a hospital in Massachusetts that had that settlement with the patient, and they basically said this was a case of discrimination because they had a protocol in place that if somebody has a chronic medical disease, they consult that specialist to weigh in on the transplant evaluation, but they did not do that for this patient that had opioid use disorder and buprenorphine. So there was nobody consulted from an addiction medicine team or pain team or any effort even made to get another specialist involved, but the patient was categorically declined. As part of the settlement, the patient, or it was required that the hospital, everybody working in the hospital received training on the ADA, and they had to put up signs everywhere saying we are in compliance with the ADA. And if you're not in, if you feel like you're being discriminated against based on a disability, this is what you need to do to report it. And then this is one of the few settlements that actually has a monetary settlement attached with it. And the reason why was because this patient moved from one state to another state to a different transplant center. Not every hospital is a transplant center, so they actually had to move from one state to another. Their caregiver, which was their mother, had to give up their job and had costs associated with that. So they got a monetary settlement for all of that. But by the time this case was settled, this patient had already gotten a transplant at a different institution. So to answer all the questions that we asked earlier, if this seemed just, right, as far as distribution of resources go, no. This patient was being discriminated against based on having a disability and a chronic medical disease. So this was absolutely not just in our how we interpret our medical ethics. And for medical justice, for the ethics principle, one of the 4 guiding principles we follow is that no patient should be unfairly disadvantaged in accessing healthcare. This is absolutely a potential ADA violation. This patient was categorically declined from a healthcare service without an individualized assessment, and the settlement proves that. And what could we have done to advocate for this patient if we were their doctor or their case manager, anything like that? And this is, I think some of you said that, talking to the other providers to educate them about opioid use disorder as a chronic medical disease, and then also to tell them about the ADA. So even if people unfairly, unjustly don't buy into the opioid use disorder as a chronic medical disease, they're still doing something illegal, and they should be aware of that. And if then they still refuse to evaluate the patient, you can absolutely report a violation of the ADA. And we will talk about how to do this after our next case. So this next case is a 32-year-old female. She has opioid use disorder. She is on buprenorphine, and she's seeking treatment for PTSD. Which is post-traumatic stress disorder. She calls a psychiatry clinic, so she self-refers to a psychiatry clinic to make an appointment. And the clinic polls her Casper, which is the state prescribing system, about if she's received opioids. It has buprenorphine on there as she's prescribed by her provider, and they leave a note on the Casper saying she needs to be off her buprenorphine for several months prior to establishing care with them. And now, with everything that we've learned about the ADA, I'm going to ask you, do you think that this is a potential ADA violation? Is this just with medical justice? And what could you do to advocate for this patient? See something in the chat? Yes, it's a violation. Okay, call the psychiatrist once. Yes, seems like a categorical denial. Absolutely, right? This person was not evaluated by the psychiatrist. They just wrote it on the Casper and declined services. Any other thoughts?
It seems like, again, you may want to ask for the reasoning behind
Yes,
the denial. If there's a condition of doubt, you would want to rule out, is it patient related or policy related?
absolutely, right? I think Carl brings up a very important point. What's the clinical reasoning behind it? Because there are some providers that are not comfortable providing treatment for opioid use disorder. And I'm an internist, so I don't do very many procedures. I'm not comfortable offering people surgery, right? But I would refer them to somebody who then can do that surgery for that patient. And similarly, maybe the psychiatrist, for whatever reason, doesn't feel comfortable providing care for opioid use disorder. However, this patient is not asking for care for their opioid use disorder. They already are getting that treatment somewhere else, and they're asking for care for something completely different. So I think that's an important thing to highlight, maybe that, that the provider might not be understanding. And even, and one of my favorite examples is, so for example, if you're an orthopedic surgeon and you've specialized in elective shoulder surgeries, right? And somebody comes to you with concern wanting a hip fixture or like an artificial hip, you wouldn't categorically deny them, right? You would say, I don't do these services because this is my specialty and I no longer do this. I'm going to refer you to somebody else. So even if this is something that falls within the realm of the practice of that specialty, for whatever reason, somebody might have specialized on something else. Yes, absolutely. As Katrina points out, the instructions that this patient must be off MOUD is what flags this as a violation, right? This is a categorical thing. This patient wasn't even evaluated by the clinic. All right, you guys are getting the hang of this very nicely. So let's move on. So this is the first settlement that I'm aware of that happened in Kentucky that used the ADA to prevent discrimination against a patient with opioid use disorder. So the settlement basically pointed out that you cannot withhold medical care for a patient based on being on MOUD. And that's exactly what was happening in this case. This patient was refused appropriate medical care because they are on MOUD. So as Katrina said, the fact that it was flagged on the Casper, written on the Casper, that's what makes it an absolute clear ADA violation. And if a provider is lacking the expertise to treat the condition, they don't have to treat this condition, but they have to refer to a provider who can. And interestingly, this comes actually out of the an ADA settlement around a patient with HIV who was seeking care for a dentist. And the dentist said they couldn't provide the care because they didn't know how to treat HIV. So from, several decades ago, from a different chronic medical disease that was applied here. So super interesting to me from a medical standpoint. The clinic has to commit to providing non-discriminatory care for patients with opioid use disorder and ensure that they're in compliance with ADA. So they have to post their updated policy in regards to the ADA everywhere where patients are, in the reception area, examination rooms, things like that, on the website. And then they also have to have sources on there, what the ADA is, what compliance with the ADA means, things like that. They have to train all their staff on the ADA as well. So that's a common theme from the settlements, is that people have to be trained on it. So this is not always a punishment, right? But also an opportunity for people to learn so they can provide better medical care. Something in the chat. Is it the clinic that is receiving the referral that's responsible for referring to another provider, or is it the responsibility of the referring clinic to find alternate, more appropriate clinic or provider? This comes up frequently among subspecialty clinics and seems more nuanced, but perhaps it is not. So that is, I would agree, it's a little bit more nuanced. This is something, from my understanding, is that the clinic should evaluate the patient, right? And once they determine that they cannot provide the service, then they can either refer back to the PCP, so they can refer somewhere else, or they can refer to a different subspecialty. So the fact that the patient wasn't even evaluated and given the opportunity to be referred somewhere else, that's the violation. All right. Oops. So going through this, this is absolutely not just, right? As we've said, this is a patient was being discriminated against for having a disability and a chronic medical condition. And this patient was unfairly disadvantaged in accessing the healthcare system. So a violation of our ethical principle of justice. This is absolutely an ADA violation, and it was settled in a settlement statement. And now let's talk about our roles as advocates. So, like, I'm a physician, so that's what I'm most familiar with. And the American Medical College the AMC has actually released what it means for us to advocate for our patients. But in general, I think this can be applied to other disciplines as well. And you might have your own associations that have statements centered around that. But as a physician, it's my duty to make sure that every individual patient receives the best care. And for the best care, sometimes it means we have to at least meet the standard of care. And the standard of care for opioid use disorder is medication for opioid use disorder. So by asking our patients to not be on medication for opioid use disorder, we are violating the standard of care. So the pure basics of medical care. But then it's also our duty to address root causes of health problems. And we know that people are still dying from opioid overdoses. And we know that less than 10% of people that could benefit from being on medication are currently on medication. So to increase access to medication is absolutely critical. And that's why it's so important for us to advocate for every single patient to maintain access, but then also to talk about how do you report these violations and how can we make this a system-wide change so that not every single patient has to go through this fight all the time. And that's where I want to highlight where we can advocate, like, how, once we've identified a violation of the ADA, can we report this? The easiest place to remember is ada.gov, and that's the general government website that has all the different definitions. What's the ADA? What's a violation of the ADA? How do you report it? On that website, you can't actually report, but it takes you to civilrights.justice.gov. So one takes you to the other. So you can either start out on civilrights.justice.gov, or if you can't remember that, ada.gov, it will take you there as well. And I know sometimes when I, am dealing with all these things, it's hard to remember everything. So the easier, the better. And if you report it there, it'll go from the top of the government down to whatever assistant U.S. attorney is appropriate for your district, and then it gets like trickled down like that. So as everything with the government, that does take some time. And so sometimes it's easier if you know who your assistant U.S. attorney is to contact them. Each state is different and each district is different. So Kentucky has Eastern and Western. I'm in Lexington, so I'm in the Eastern Kentucky district. Our assistant U.S. attorney is Carrie Pond, and you can find how to contact her on the website. And it actually has like a specific link for ADA violations. Depending on the priorities of the assistant U.S. attorney, it might not be right at the website, what district you're in. So if you can't find it, you can always go from the top down. There's other nonprofit organizations here in Kentucky. There's the Legal Action Center, and actually Vital Strategies works with them. They have fantastic resources on their website, including letters that are pre-populated with different settlements that you can use to send to, for example, SNFs or rehab facilities if they decline your patient. And then also the American Civil Liberties Union is taking on this cause as well. All of these resources are free. So that's, sometimes my patients don't have a lot of financial means. And so this is a good thing to refer them to and tell them it's free if you want to utilize it. Patients also can get a private attorney, but oftentimes that's associated with a charge. So now that we know where to file an ADA violation, let's talk about how to file it. And the first thing we need to identify is it's a potential ADA violation that we are witnessing. And I want to be very clear, it's not on you to figure out if it is a violation or not. If you see something that you think is a potential violation, report it, because it's up to the assistant U.S. attorney to then figure out if that's a violation or not, and if they want to investigate it further, if they want to pursue a settlement, things like that. That is, they're specifically trained on that. They know how to do that. And if you report something that's not a violation, maybe it looks like that public entity is discriminating in some way, and they should be aware of that, so that even if they're not intentionally discriminating, they come across as if they are, so that they can change that practice. So from my standpoint, there's really no downside to reporting. And you want to make sure that, and I think Katrina and Carl pointed this out in the chat, that this is based on a policy, not an individualized medical assessment. So if a physician sees a patient, does an assessment and says, because of this, this, and this, we can't accept the patient, and one of them is because of something related to their MOUD, but it's patient specific, not a policy, then that is not an ADA violation. So just being very clear on that. And I think my next case will illustrate more what I mean by policy. And then I always like to document everything, because as it happens, it's fresh, right? So I take little notes either on a notepad or in my email. And then I'm able to provide those when I submit a case. And if I were ever called upon it for some sort in the settlement, then I would have my notes from that specific day. Because as I've mentioned, some of these cases can take a long time, and it's hard to recall something that happened several months or several years ago. And then you just submit a case for to be investigated for potential ADA violation. So it's fairly easy. You see it, you make sure it's based on a policy, you document it, and you submit it. I think it can still be a little bit scary to do that. Sometimes people ask me, well, I have so many other things to do, like how do I find time for this? And often it takes less than 10 minutes. And I think we all have that time in our schedule to ensure that our patients have access to medication that's going to keep them from dying. Something that often comes up is people ask me, what about HIPAA, which is the Privacy Act that relates to patient information. And the Department of Justice is actually a governmental oversight agency. So in theory, they are exempt from HIPAA, and they can just go to a hospital and request patients' records, and that is not a HIPAA violation. However, substance use is specifically protected also under 42 CFR Part 2. So sometimes institutions will not release information related to substance use based on that special protection. And what I typically do before I report a violation is I talk to my patients and I inform them, first of all, of their right that this is a violation. And most of my patients don't know this. I've actually never had a patient that knew that they had their access to their medication for their opioid use disorder was protected under the ADA. So that serves two purposes. Now I've educated the patient and given them the power to advocate for themselves, but now I also can get an assigned consent form and let them know that this process is ongoing. And that also serves for the fact, first of all, it makes it easier for the assistant US attorney to get documents. And then also the patient isn't surprised if they get a call from an attorney wanting to speak to them about their MOUD, because as you can imagine, if that comes out of the blue, that would be very off-putting for most people. And I also encourage the patients and say, hey, I'm going to report this, but I empower you to report it too, because if there's number one, more reports, I think that gets more attention. And then also to give patients that agency to advocate for themselves so they can teach other people how to do it and empower them really to take their healthcare into their own hands too. I'm usually available for the assistant US attorney if they have follow-up questions or need more information from me that I can provide, but that's not something you have to do to report a violation. But I always think the more information they can get, the more quickly they can resolve the violation and the quicker our patients can be helped. Some other considerations, this is not going after an individual provider. So as a physician, for me, it would feel very sticky and bad to report another medical provider to an authority position like that, right? This is not, we're not going after individual physicians. In the settlement, it never mentions individual providers. It's always the public entity. And this is not meant to be punitive, as I've said before. This is basically the government being a good big brother, taking public entities and making sure they're not violating the ADA. Because as I've mentioned, there is usually not monetary settlements associated with it. And if they are, usually they're smaller sum. So it is in the public entity to go in their best interest, I would think, to go into a settlement with for an ADA violation, ensure compliance with the ADA, rather than getting, like, for example, a malpractice lawsuit, which often has more financial and negative public perception associated with it. So the goal of these settlements is not to punish the institution, but to actually make sure they're in compliance with the ADA and to have them be able to better serve the general public. In addition, just something to be aware of, the assistant US attorney represents the United States. So the settlements will say United States versus so-and-so, versus this facility, because they do not represent individual patients. So if your patient wants individual legal representation for whatever reason, the assistant US attorney is not the person to go to. They would have to find a private attorney to take on their case. And that is how to recognize an ADA violation, how to report it, where to report it, and some common questions I've gotten about reporting answered. So I'll pause here again for a second to answer some more questions. I think we have plenty of time. All right. And if you ever want to file a complaint and are unsure of how to do it, I'm happy to, walk you through it or give you share some of my experiences to make it easier. Carl, it looks like you unmuted yourself. Did you have a question?
Yeah, I have a rainstorm going on, so it's a little hard for me to hear, but my question is for clinicians. Should we get a separate consent for patients if we are going to go down that road and report a potential ADA violation? Is that what you're saying?
So you don't have to, because technically, like I said, the Department of Justice is an oversight agency and they can request records. However, I think I always do, just because first of all, then I'm for sure covered under HIPAA. I'm for sure covered under 42 CFR Part 2. And then it also, the patient is aware. And then a lot of times on the consent form, I would put like the patient's phone number, contact information. So I think that just makes it easier for the Assistant US Attorney to investigate all of that. So I would say yes, from a practical reason, but it's not absolutely required. I've had it before that then records related to substance use were not released because of 42 CFR Part 2, and it required the Department of Justice to go to through specific hoops and delay the process.
Great,
And I
thank
also
you.
think, no, of course, I also just think it's nice if our patients know what we do so they can give true informed consent. All right, and with that, we'll go to our third case. And I think this will, in a roundabout way, address the formulary question that was asked earlier. So this is a patient that I see a lot in my practice as a hospital medicine physician. This is a young patient that is incarcerated at a county jail, but hospitalized for an injection-related infection. He receives appropriate medical management of his infection, and I meet him in my capacity as the inpatient addiction medicine physician. We talk about his history of substance use. He meets criteria for his opioid use disorder, and he would like to have treatment. This is the first time he's ever offered treatment, and he would like to have buprenorphine. And before I leave the room, the guard kind of stops me and says, "Hey, why are we even doing this? He can't have the Suboxone in jail. So what's the point?" So with that, I'll open it up to the group again and see what are some of the complicating factors that you can see with this third case. And does the ADA still apply? This patient is incarcerated. And what could you do to advocate for this patient? Yes, absolutely. Katrina says categorical denial of MOUD in a public entity, in this case, the jail. This is a violation, right? I mentioned jails are public entities, even private paid jails. Absolutely a violation. So you guys are getting the hang of identifying violations, which is great. What could we do to advocate for this patient, especially knowing some complicating factors, maybe identifying those? Yes, so Katrina says that Kentucky regulations for buprenorphine prescribing are a complication. Absolutely, yes, having to see somebody within a week. However, I would counter that by saying there is a physician in the jail that sees patients. And as Chris mentioned at the beginning, the X waiver is no longer in effect. And even though you never needed an X waiver to continue buprenorphine in an inpatient setting. Yes, financial resources available to provide MOUD, right? Prison medicine is underfunded and people do need resources to pay for these medications, absolutely. And I'll share, for me, it's very challenging. Oh, lack of nursing staff, right, to distribute daily medication, right? For me, it's like even the barriers, even before that, you guys are focusing a lot on the barriers in jail to get medication. But for me, the barriers even, I have a patient who wants treatment, but I have another authority figure, the jail guard at the bedside, saying they can't have it. And that's not somebody that's making medical decisions for this patient, but interfering with their treatment. And how do I even navigate that? It's challenging for me a lot of times. Alyssa says, if the patient's substance use while in jail caused infection, MOUD could be a cost-saving measure for them. Absolutely, right? They're paying all this money to have this patient in the hospital for weeks or months at a time to treat this infection. But if he wasn't injecting, but his opioid use disorder was treated with MOUD, that would never be an issue. and cost saving. And absolutely, there's actually a study that recently came out that shows that offering MOUD in the carceral setting does decrease costs. So absolutely. And then Samantha says the client's length of incarceration and potential transfer to another jail facility where BUP might not be offered. Absolutely, right? This is somebody that is in jail. They haven't had their day in court yet. So we don't know how long are they going to be incarcerated? Where are they going to go? There's a lot of factors as this person moves through the system. Is this policy or just lack of understanding of MOUD? Can we provide support, information or support to the provider on site? Absolutely, right? Like this is a jail guard that's saying this, but maybe talking to the provider gives us more insight. Is this, first of all, is this even true? And second of all, what's the barriers? Like asking straight at the source, what are the barriers to initiate MOUD? And is it, something like stigma from the provider side? Is it a knowledge gap? They don't know how to manage buprenorphine. Is it a cost thing? Is it a concern for risk of diversion? As somebody mentioned, is there enough nursing staff to administer medication? Things like that. Absolutely. All right. So, as I mentioned, there's lots of various, something else in the chat. I see this all the time that we have patients that come in on MOUD, but it's not continued, even though they are compliant with their treatment. It also has to do with a few of the staff, is what April says. Absolutely, right? There's still a lot of stigma in the community towards MOUD. And if somebody is on MOUD prior to incarceration and that is stopped upon incarceration, that's a clear violation of the ADA. And I'm not sure which jails or prisons you work with, but I would absolutely encourage you to report that because that affects a lot of people. And working on getting prisons and jails in compliance with the ADA to increase access to MOUD, I think is crucial in our current overdose crisis.
This is Shirley here. I'm at the Boyd County Detention Center.
Yeah.
And recently there were some laws passed here in Kentucky that says because there was an ADA violation filed through Fayette County because somebody came in on MOUD and they wouldn't give it to them. So the policy here is now that if somebody comes in on MOUD, has an appropriate drug screen as far as not using other illicit drugs, that the treatment is continued here. As a matter of fact, it's encouraged here. And we are currently writing a grant through the abatement program here in the state to get a Vivitrol program back in here. So that's the nice thing about Jailer Hensley is he's about trying to do every avenue with that. And I'm the one that told him, like, this is an ADA violation. You cannot tell these people they can't have their medication. So we have several in here that are taking it currently that are incarcerated, and he doesn't have a problem with it. So
I love that. You said that was Boyd County?
yes, ma'am.
Wonderful. So that is great. So the Fayette County case is going to come up later. So there was a settlement here in Kentucky with the Fayette County Detention Center that MOUD has to be continued upon incarceration. And I'm glad that other facilities are following those ADA guidelines. And I'm so happy to hear that you pointed out about the ADA violation. And I do think there's a lot of grant money out there that people can apply for MOUD. One thing I would caution on from an addiction medicine physician perspective, we do see a lot of people that are using multiple substances, so have a comorbid opioid use disorder as well as maybe a stimulant use disorder, or smoking marijuana, drinking alcohol, and so that would show up on the urine drug screen, obviously. And I think these people should still be allowed to continue their MOUD, so continue their buprenorphine or methadone, because as I've mentioned before, illicit substance use should not prohibit you from receiving appropriate medical care. And the American Society of Addiction Medicine actually supports that even if there's other substance use, as long as people are taking their MOUD to continue that. So maybe something to look at for the people that you are seeing. But I love that Boyd County is doing all that, and would love to
We are
chat.
heading in that direction. I believe
Uh-huh.
it's going to come down to that they're just not
Love
going to be
that.
able to refuse it, period. I've also, I don't know if my case will come up in this discussion or not, but I had an ADA I filed against a hospital here. They refused me psychiatric treatment, mental health help, because I was on Suboxone. And I filed an ADA against them. So
Yeah, which hospital was that, if you don't mind me
King's
asking?
Daughters Medical
Yes,
Center.
that's the, yeah. So I modified some things in the case, but yes,
Sorry, I don't mean to
absolutely.
get you ahead of
No,
yourself,
I
but
love
I
that.
think
I
we
love
are
that.
heading in the
That
right direction here as
I
far
think that's
as
great.
allowing them to continue the treatment.
I think I'm so amazed that all this hard, good work is going on. And I would love to chat with you more and maybe connect and see if we can even work together on some of these things to make it more speedy in different areas of Kentucky. I love this. Thank you for all your hard work and advocacy and advocating for yourself too. I think that's so amazing.
Thank you. And I would love to work with you on this. I think it's important that once they added that clause in there about substance use disorder, people don't know that we are covered under that now. And I think
No.
it's very important that we educate, I call it our people, because for so long we have been discriminated against in that way.
Right.
And I think it's vitally important that we know our rights.
Absolutely. And I think sadly too, sometimes people have been discriminated against so often that they don't even recognize the discrimination anymore because they've become so numb and so expecting to it. So educating people, empowering them, and then for us as providers to be there to help them in that is, I think, vitally important. So thank you for that comment. I love it. Yes, and Alyssa says, as another local agency who has made a lot of ADA reports about jails, prison, we have actually seen policy change as a result. So it's worth it for sure. I love that. This is how many people are here. We have about 40 people here, and multiple people have reported ADA violations and have seen positive policy change. So that is lovely, lovely, lovely. All right. So yes, people that are incarcerated and have opioid use disorder and are on MOUD are still protected by the ADA. So I think we've driven that point home, but just something to remember. And a lot of times people who are incarcerated are the ones that have the least ability to advocate for themselves because they might not have access to resources and they are in a vulnerable position. So I think just keeping that in mind, that's even more important that we do that work for them in this point. And yes, so this requires a multiple step approach. I think we're going to run out a little bit of time, so I'm going to be super quick, but I just want to point out people that are incarcerated are the only population in the United States that do have a right to healthcare. This is from the 8th Amendment that prohibited cruel and unusual punishment. And that initially was meant to apply to bond money, that bond money couldn't be too high. However, the Supreme Court has had multiple cases where they said this applies to medical care too, and that withholding medical care shows deliberate indifference and is a cruel and unusual punishment. So that's kind of how this amendment is interpreted for healthcare. And that means that the standard of care doesn't change when somebody gets incarcerated, and incarcerated people should have access to the same standard of care as people that are not incarcerated. And for opioid use disorder, that is MOUD. So no question about the 8th Amendment applying to that as well. So just another tool in our advocacy kit to use. These are the case settlements that clearly find that discontinuation of MOUD as a blanket policy is a violation of the ADA. So the first case that I was aware of for that is the Pesca versus Coppinger, that's out of Massachusetts and from 2018, and that pertained to one particular individual that was going to get incarcerated and was allowed to continue their methadone upon incarceration. And in the settlement, they cite the 8th Amendment, but they also cite that discontinuation would represent an ADA violation. And this is what I mean when I say some of these settlements came before the Department of Justice put this as an official policy. Then there were other cases around that all came out with the same settlement, that people were allowed to continue their MOUD. And eventually those settlements did not only apply to individual plaintiffs, but to entire populations of patients with MOUD. There's also settlements out of the parole board in Massachusetts, and that was requiring all patients to be on Vivitrol. Whether they were on a different MOUD or no MOUD, everyone was required to be on Vivitrol without an assessment by a medical provider, and that was ruled to be an ADA violation. They had to offer all three or allow all three forms of MOUD, and they had to be evaluated by a medical provider to see which one was appropriate for each patient. However, unfortunately, not all jails or prisons are currently in compliance with the ADA. And that just means for us, there is more continued advocacy needed, as is being pointed out, is happening in Boyd County. So to return to our case here in the hospital, we started this patient on sublingual buprenorphine because that's what the patient was interested in. And we called the county jail and talked to them, and they said their policies only court-ordered and pregnant patients were allowed to take medication for opioid use disorder. And they did not perform an individualized assessment based on their, to see if the patient was allowed to continue their MOUD. So we knew that this patient wasn't going to be allowed to continue buprenorphine upon incarceration. And what we did is we administered Sublocade, which is the extended release buprenorphine, to provide treatment for as long as possible. But unfortunately, Sublocade lasts 30 days with a little bit of a tail after. And a lot of times the incarceration lasts longer, as in this case, our patient was incarcerated for about 90 days. We arranged for him to have a follow-up appointment to get a second injection of the Sublocade while he was still incarcerated, but the jail refused to transport him to the follow-up appointment. They did provide follow-up appointment to transport to other follow-up appointments related to wound care or infectious disease. So despite precedents from other states and multiple settlements saying that this is a clear violation of the ADA, they refuse to be in compliance with the ADA. And I only have 15 minutes left, so I'm going to speed through these next slides a little bit. I just want to highlight people that have opioid use disorder are overrepresented in the carceral system. This is from a survey-based study that found out on a population level about 80% of people that use heroin via either route are at some point in their life in contact with the justice system. And we do know that people that are incarcerated are at a high mortality after release from incarceration. This is a study out of Washington that looked at 30,000 released people. And out of these people over this 4-year time period, 443 of them died and 250 of them within 1 year after release from incarceration. And I want to point out these are young people, 18 to 44. So this is not a population at an age that should be dying at this high rates. And when they looked at causes of death, overdose was the #1 cause of death. And I don't think that's surprising if we have people that are going to jail or going to a facility where they are forced to detox, but are not being given medication. They lose their tolerance. And then when they return after this very stressful event of incarceration, it's common that a return to use happens because the chronic medical disease wasn't treated. And this is one of the figures from this study that really speaks to me. They've applied a statistical method to look at deaths per 100,000 person years. And if you look at these bars, it just shows that within 2 weeks, the risk of dying after release from incarceration is incredibly high. And in those first 2 weeks after release from incarceration, the risk is 12.7 times higher than among other residents in the state. And overall mortality for people that have been incarcerated is 3.5 times higher than in the general population. So incarceration in itself is a social determinant of health that's associated with increased mortality, and especially for our patients that are using substances who are overrepresented in that population. But looking at some studies, what happened after MOUD was allowed in carceral settings, this is from the Rhode Island Department of Corrections. After they've had MOUD with all 3 medications, they've noticed a post-incarceration opioid overdose reduction by 61% in the first year after implementing an MOUD program. In England, they noticed a significant reduction in all-cause mortality and opioid overdose within 1 month post-release. So this is data that is applicable globally. And then in Australia too, they found that once they've allowed MOUD in the carceral system, they had a decreased risk of suicides in the carceral system. So I think overall, this keeps people from dying, and especially in this very vulnerable patient population while they're incarcerated and after release. This is the first study that looked at MOUD in the carceral system, or one of the first studies here in America. And this was revolutionary at the time, a randomized open label trial in the Rhode Island Department of Corrections, where people that were incarcerated that were already on methadone were allowed to continue that methadone rather than being forced to withdraw from methadone. So the intervention was actually that they were allowed to continue the medication for their chronic medical disease. And they looked at outcomes at 1 month and 1 year, engagement in care, self-reported injection use, non-fatal overdoses, deaths, and emergency visits. And here in the intervention arm, so these were people that were on MOUD prior to incarceration and were allowed to continue it. That was the intervention. So they didn't start anybody new, but they found that they had a way higher return to the methadone clinic at 1 month after release. And more of these patients were engaged in treatment with methadone 1 year after release. The people that were allowed to continue their methadone while they were incarcerated had a decreased rate of self-reported injection drug use and heroin use, and they had a decreased rate of self-reported non-fatal overdoses. So this shows us if somebody is on MOUD prior to incarceration, they should be allowed to continue it because it's going to increase engagement in care and decrease their risk of dying. And then this is focused on buprenorphine initiation during incarceration. This is also out of Rhode Island. And initially, this study was intended to start everybody on buprenorphine that was enrolled in the study, but due to some difficulty getting the buprenorphine into the carceral system, it actually developed into this 2-arm study of some people that were started on buprenorphine prior to release from incarceration versus some people that were just set up with close follow-up. And this is why the study is so interesting to me, because the people that were on the buprenorphine prior to release from jail had only been on it for a very short time. Average was 1 week. So that's usually not a very long time of being engaged in treatment. And out of those people, almost all of them attended the follow-up appointment, and 10 out of the 12 people were still remained in care at 6 months after release from jail. So for me, this is a phenomenal number. These are people that were not on MOUD prior to incarceration, got started for a very brief period before release, and then most of them were retained in care at 6 months. So that's, very convincing to me. And none of them had any overdoses or reported illicit opioid use. And this was the larger arm, the unintended arm of people that they didn't get to start on buprenorphine, but that were referred to a clinic. And they did provide transport for these patients. So they might have, had maybe a more easier access to access the buprenorphine clinic. But even out of this arm of people that were not started, about 1/3 of them were retained in care at 6 months. So while ideally we would offer medication to everybody and start everybody, even if that's not possible, referring them to a close follow-up still increases engagement in care. What is the current state of MOUD? So Rhode Island had an executive order in 2016 that allowed all 3 MOUDs for all patients with opioid use disorder. Vermont in 2018 passed a legislature that meant everybody was allowed to continue MOUD. They screened all incarcerated patients for opioid use disorder within 24 hours of arrival and offer all 3 forms of MOUD. Maryland is started implementing something in January 2023, allowing all 3 MOUDs, and then New York as well. So we have a few, I know Massachusetts is also working on it. We have about 5 states that are leading as shining examples. However, then there's the downside. Alaska, everybody gets a 30-day taper for people that were on MOUD prior to incarceration. So that's a clear violation of the ADA. In Iowa, only people that are pregnant are allowed to be on MOUD if it's deemed medically necessary. And once the patient has delivered, MOUD is stopped. So once again, a blanket policy, a violation of the ADA. And then a lot of other states only allow extended release naltrexone or Vivitrol at the time of release from the carceral system. And as I pointed out earlier, this is the only MOUD where we don't have data that it is mortality reducing. So, oops, we already had that. So to recap, MOUD with buprenorphine and methadone reduces all-cause mortality. If it is started or continued during incarceration, it does increase retention in care. However, most jails and prisons currently do not offer all 3 forms of MOUD. And often, if MOUD is offered, it is in the form of extended release naltrexone, the one medication that is not shown to reduce mortality. So going back to the case of JJ, or like I've seen a lot of patients like this, he's willing to receive treatment for his opioid use disorder. He's interested in recovery, but he was prohibited to do so by the jail. When he was released, he did not engage with with medication for opioid use disorder. He has not been seen by an addiction medicine clinic, but he's presented multiple times to the emergency room with injection-related infections and once with an almost fatal overdose. So from a society standpoint, we've really had an increased cost in healthcare in his case. And from an individual impact, he's had an increased morbidity, chaos from addiction, and potentially mortality. He is at high risk still of dying from an overdose. And this to me is such a hard case to think about and talk about because he was willing, he wanted treatment. We had a window, we had an opportunity, and we lost that due to the jail violating the ADA. How could JJ's case have been different if he was in Rhode Island or Vermont or one of the other states I've mentioned? He would have been screened for substance use upon incarceration. He would have been diagnosed with opioid use disorder using the DSM-5 criteria, just like I did when I saw him in the hospital. He would have been offered medication counseling on all 3 FDA-approved medications. He would have been evaluated to see which medication was most appropriate and most served his goals and his needs at this time. And then a patient-centered decision for best treatment approach would have been made. Should he have chosen buprenorphine, he would have been started on buprenorphine and continued on buprenorphine the entire time he was incarcerated. And then he would have been linked to care upon release from incarceration so that he could continue treatment for his chronic medical disease. And I just want to point out, as we've discussed, this is possible in Kentucky too. This doesn't have to be a far dream in Rhode Island. We can do this around here. We do know that there is a settlement with Fayette County, as was pointed out. So that says withholding MOUD for a patient with opioid use disorder is a violation of the ADA. And they do need to continue MOUD to ensure ADA compliance, but they should take it a step further and really screen everybody and offer MOUD to everybody. And unfortunately, this settlement only applies to one facility. So we need to advocate with our jails and all the other facilities where our patients go so that they are in compliance with the ADA. And if we encounter barriers, we absolutely need to file reports so that our assistant U.S. attorney can reach settlements and can increase access for opioid, for MOUD. So with that, I have about 4 minutes left. So I'm going to talk about the settlements. We kind of went through the different cases. The first one was the case of the patient I mentioned in Massachusetts General Hospital, where the patient was refused to be evaluated for a lung transplant. And the settlement basically said the hospital cannot screen out an individual or a group of individuals, patients with opioid use disorder, from receiving healthcare services. The King's Daughters case was mentioned, so I feel very honored that you're here today. And that basically showed us providers cannot refuse to provide care for patients due to being on MOUD or demand for patients to stop MOUD to establish care. I've mentioned the cases where the ADA was violated for people that got incarcerated. So this is one of the cases, the first one that allowed an individual to continue MOUD upon incarceration. And then I already talked about the Massachusetts trial court cases where the decision was made that decisions on MOUD had to be made by a medical licensed provider on an individual basis and could not be a blanket statement by the parole board in this case, or the drug court. And similarly, a drug court cannot mandate for everybody to be on one form of MOUD. And those were the cases that we discussed today. So hopefully, looking at all these cases, you remember the highlights from each case and how you can use them to advocate for the public entities to be in compliance with the ADA so that our patients and people don't have to stop MOUD when they transfer their care somewhere else. And with that, I would like to acknowledge the Bell Scholar and the great mentorship that I've been fortunate enough to receive from Dr. Michelle Lawful for the Bell Scholar. I also work for the UK, the University of Kentucky Addiction Counsel and Education Service, and this is grant funded. And I've been working with an academic writing fellowship program as well that has helped with the development of the slides. Some of my sources, and I think for that we'll take it to the CME credit.